So we've got a few talks, and I've got a panel with me this evening who's going to cover hopefully lots of questions that you have and get you inspired for a career in medical oncology. So my name's Simon Pacey. I'm the clinical lead for recruitment. I'm also the TPD in the east of England. I've got Satinder with me, who is our chair of the Medical Oncology National Training Committee, among other things. We've got Richard and Alistair from the Association of Cancer Physicians Training Committee. So they're going to give you their views on entering the career. Stephen Harding should be joining us, who is, again, amongst his roles, manager for the PRSO recruitment process. So our expert to keep us honest about answers about the recruitment and the expert advice we need there. And Alison Norton's with us. I'm going to acknowledge Alison, who's intensely helpful from the ACP and making sure we get these events organised. And you saw our sponsors on the previous slide. So we're going to go through some brief talks and then have plenty of time for discussions around half an hour's time. So just to set the scene, I was going to put one slide up. This is again taken from the ACP website. There's a variety of career information there if you have a chance to have a look at. And we often get asked what medical oncologists actually do. And you can see here it's summarized in these two paragraphs. So we are responsible for overseeing the treatment of patients with cancer. So this would involve discussing treatment options, supervising systemic treatments, and supporting patients throughout their care, liaising with other members of the multidisciplinary team. You can see on the left in the pictures some of the opportunities that a career in medical oncology opens up. And as patients live longer, treatment's getting more complex. And so the speciality continues to be one of the fastest growing, with lots of exciting changes that are making a difference to patients' lives now and over the course of your career if you choose to come into the speciality. You can see that most of us will specialise in up to 3 tumour areas or other things such as acute oncology, looking after patients who require specialist input when they're acutely unwell or suffering from side effects of therapy. And you can see there that training involves rotations through the major acute tumour types, becoming competent in a variety of different systemic therapies and working, as I said, in a multidisciplinary team. And then I've just added at the bottom there as a reminder, medical oncology is a relatively new speciality in the UK, probably starting sort of in the 60s and 70s as chemotherapy was developed from the back end of the 1940s. And then we've gone through a decade of developing targeted therapies, which distracted us from cytotoxic chemotherapy, and then targeting the immune system around 2010. And you can see that the sort of speed of change, having had systemic chemotherapy for decades, we've now got lots of different treatments coming through. Targeting the immune system's made a huge difference in a variety of tumor sites that colleagues I'm sure will talk to you about. And then we've now got lots of other therapeutic options coming, listed in there in the purple. So advanced therapy products, gene therapies, cell therapies, working with colleagues in nuclear medicine with radionuclides and things like antibody drug conjugates. So there's no shortage of work and new ideas coming through, which will be happening over the next few years and decades. So that's enough of me rabbiting on. I'm going to pass over to Satinder, who is going to give you a consultant perspective of a career in medical oncology.
So good evening, everyone, and welcome to this webinar. Really pleased that you're joining us to hear a little bit about medical oncology. So as Simon said, I'm a consultant medical oncologist at Leeds Cancer Centre, and I'm also the chair of the Medical Oncology Specialty Advisory Committee for Training. And I'm just going to give you a short overview, really, of a consultant's perspective, and also really think about where could medical oncology fit in for you and what could be the future prospects. So just thinking about why medical oncology. So as you've heard from Simon, medical oncologists deal with the management and support of cancer patients with systemic anti-cancer therapies of many sorts, and the range and the application for those therapies is ever expanding. So we often find ourselves in a coordinating position when it comes to the patient's journey, because we use these agents in different settings, sometimes in the curative setting, sometimes in the advanced setting. So we have a really holistic view of the patient pathway and the patient journey. And with the aging population, not only are we looking at the complexities of the diagnosis of cancer for our patients, but actually we're dealing with their comorbidities, we're dealing with their other problems, and also the family dynamics and psychosocial sequelae of a diagnosis of cancer as well. And indeed, I mean, my job certainly as a consultant over the last 15 years has changed dramatically in terms of what I do with the treatments that I give on a day-to-day basis, and that's because of the research that is going on in many fields that are related to cancer care, particularly in drug development and development of technologies to treat cancer patients. And so really it's an exciting specialty where where our day-to-day business is really changing fairly rapidly. And there is lots of liaison with other specialties. We work closely with our clinical oncology colleagues and other colleagues in the multidisciplinary team. So it really is a team approach to cancer care. And within medical oncology, there are many opportunities to develop your career in different directions, which I'll talk about, and also opportunities for personal development as well, depending on your interests. There are a range of settings to work in. So some of us work in cancer centres, some of us are based in cancer units in the district general hospitals, and some of us work in both. So we cross both of those settings. And there are excellent networks, both regionally, nationally, and internationally, with the ACP, of course, being one of them. So what type of direction can a career in medical oncology as a consultant take you? So there is the core NHS clinical part of the job, and some clinicians like myself are wholly based in the NHS. But there is also opportunity to pursue a clinical academic career, or even an academic interest within an NHS career. And the trainees will talk a little bit more about the academic pathways a bit later on. But certainly some of my colleagues will be employed by universities to run their own research groups, run a trials portfolio, etc. But in fact, research really goes through all of our jobs as a core part of business, as we'll all see patients on clinical trials in some way, shape, or form. As I mentioned, some of the jobs are based in cancer centres, which specialist centres either are standalone, like the Christie Hospital or the Royal Marsden Hospital, or they are part of a bigger general hospital like the Leeds Cancer Centre here at St James's Hospital. And then the cancer units that are based at the district general hospitals. And then the jobs can take really any direction that people feel interested in. So certainly teaching and education, there's a great demand for both undergraduate and postgraduate education, and some clinicians will go down the clinical management route, and so look to develop their careers in that way. So what does life involve? What is involved in life as a consultant medical oncologist? So the multidisciplinary team, as I mentioned before, is a core part of the day-to-day clinical work. So this is where the new diagnoses and patients with new diagnoses of cancer and the new referrals into the service are discussed by a multidisciplinary team, and that includes medical oncologists, clinical oncologists, surgeons, radiologists, and histopathologists. And each case is reviewed individually, and management decisions are made as a team, and they will be referred onwards to the appropriate specialty. So that's part of our core business. The outpatient clinics, so the bulk of the work that we do in medical oncology is conducted really in the outpatient clinics. And these are the well patients who might be on follow-up or on systemic anti-cancer therapies. And there are often many complex decisions to be made in this setting, but in a with the support of our clinical nurse specialist colleagues and sometimes pharmacy colleagues, and again within a multidisciplinary team. And certainly a lot of the clinical trials work will be done in the outpatient clinics. So probably the area that if you're in IMT and you've done an oncology rotation or are doing an oncology rotation, the inpatient work is probably the bulk of your work. So these are the patients that you will have come across most often. And these are the patients that are admitted acutely with either complications of their cancer or complications of their treatment. And certainly palliative care runs through all of our inpatient work and our outpatient work as well. So we liaise with the specialist palliative care teams, but there's also work that we do ourselves around symptom management and supporting our patients in that way. And the acute oncology, again, is and the on-call is a big part of our life as a medical oncologist, certainly on a rotational basis, seeing the new admissions and either liaising with the acute oncology team, or many consultants will have acute oncology as part of their job plan, where you would liaise with external teams around the hospital to advise and also bring patients into the service. And then education and training. So most of us are involved in training the ward doctors and also the specialty trainees, and many of us are involved in education in some way, shape, or form. So what does the future hold for medical oncology, particularly for yourselves as people who are interested potentially in medical oncology as a career? So there's an acknowledged need to improve cancer outcomes and improve treatment access for patients across the board. And certainly, as we've heard, there are new applications for the older drugs that we use, and there are also increasingly newer agents that are becoming options for our patients. So the therapies that we have at our disposal in our toolbox are increasing, and patients are having better outcomes and living longer. There are complexities of an aging population, so there is a real need to understand the impact of patient comorbidity and polypharmacy and frailty on their ability to receive treatments, and looking at risk benefit balance when you're discussing the patient. So there's certainly a need for consultant specialists who are trained in complex systemic anti-cancer therapy. And then again, in terms of the research pipeline, there's much that is going on, and the specialty is changing all the time due to the development of new drugs and new technologies and new settings for new combinations of drugs that we already have. And so what we've seen is that certainly at this point in time, there are vacancies, and people applying to consultant vacancies can have some say in what those posts involve. Certainly, there's an expansion in oncology specialty training posts. So for yourselves thinking about a career in oncology, certainly in medical and in clinical oncology over the last few years, we've had an increased number of posts available to take on trainees in the specialty. And the many of the jobs will involve developing acute oncology services, and will depend on regional service priorities. So really, there's no one size fits all when it comes to a consultant post. There are lots of different things to think about in terms of the setting that you would want to work in, the type of tumour site that you would want to work in, and also what the priorities are of the service that are advertising the job. So generally, in terms of, these are just some general thoughts really, in terms of thinking about a career in any specialty really that would be fulfilling and rewarding. So thinking about what are the types of things and what are the aspects of this specialty that you enjoy. So certainly medical oncology is very patient-centered. There is complex communication, often difficult communication, which can be very rewarding and satisfying. It's a team-based approach. There is complex problem solving, as I've mentioned. There is being innovative, and we're often early adopters of new technologies and new developments. And it's thinking about whether that would fit what you enjoy. Certainly thinking about your strengths and how these would play into a career is important. And who are my people? So it's really, if you can get an opportunity to do a post in cancer care, or to have some time with oncologists either in clinic or in the ward setting, it's really seeing whether these are the type of people that you resonate with and you feel could be role models for you. And then how can I get a taster? And the trainees will talk a little bit more about this. But so certainly as medical oncologists, we welcome trainees coming down to our clinics, attending our ward rounds, even if they're not in that post. So it's important to get in touch with either your local training program director or oncology trainees that you know, to try and get some contacts through that. So wishing you all the very best of luck wherever you are at in terms of your career, and thank you very much for your attention.
Keep the questions coming in. We can see them in the chat there, and I'm going to pass over, I think, to Richard first of all to give us first of two talks on registrar's perspectives on careers in medical oncology. Richard, thank you.
Yeah, perfect. Thanks, Simon. So as I said, my name's Richard Heywood. I'm one of the oncology registrars up in Yorkshire, and I'm also chair of the ACP Trainee Committee. And for those of you who don't know, the ACP is the national organisation representing medical oncologists. So I've got some resources at the end, but some links to our website, which has a lot of useful information. In terms of the questions, we will address those at the end of the talks. But there's some interesting questions already, and some of the questions you're asking may already be covered in myself and Ali's talk, so we'll see if we can cover those. So I'm just going to give a bit of an outline about the training pathway and then a bit of advice about applying for it. So this is taken from the RCP website. So this is the training pathway at the moment for both medical and clinical oncology. As somebody has already mentioned in the chat, this is a group 2 specialty. So you can apply for medical and clinical oncology at the end of your second year of IMT or at the end of your third year. And I suppose we can talk at the end in the panel about the benefits of those. I think that's a very personalized decision about what you would like to do. As I said, you can do IMT 3 and then apply. You do have to now have completed your MRCP, including PACES, by the time you start. So that's a consideration for when you apply for the rotation, for the training posts. And as I'm sure you're aware, as a Group 2 specialty, we do not dual train in internal medicine, and instead we are contributing to acute oncology and managing acute oncological presentations. I've put a little bit in there about on-call requirements. Generally, the sort of nationwide, most people as a medical oncology registrar, you don't do resident nights on call. There are one or two exceptions, I think, particularly at the Christie in Manchester. And as far as I'm aware, there's nowhere else. So generally, you don't do resident nights, but you do on-calls, weekends, days, and long days as per other specialties. One of the changes in the last few years has been the introduction of the Oncology Common STEM, which is during your ST3, whether you become a medical or clinical oncology trainee, you have the same training pathway for the first year. So just to identify, this is here. So once you've been selected for a post, your first year is essentially overlapping medical and clinical oncology. What that means is that you end up doing rotations in tumour sites that have systemic therapy and radiotherapy, so you have exposure to both. And it's allowing you to just develop your generic oncology skills as an ST3 that will then stand you in good stead for your later on training. It means that as medical oncology trainees, we get a bit more exposure to radiotherapy delivery and planning in the first year, which I think I certainly found has been very helpful actually throughout my later training as a medical oncologist to understand how you deliver and the role of radiotherapy. And it does mean that if you start at ST3 in one specialty and feel like you want to change over, it then means that your competencies means you can start at ST4 in the other specialty. Although it have to be said, you do still have to go through national selection, so you can't just say I want to change it. You do have to go through that process. So one of the sort of key themes in terms of the questions that were submitted before the talk was, what is the difference between medical and clinical oncology? And it's not a really distinct dividing line between the two. As Dr. Pacey and Dr. Jagdev mentioned, there is a lot of overlap between the working patterns. So some of the sort of main differences I've just outlined here. So in terms of who runs the program, so there is a difference. Medical oncology remains under the Royal College of Physicians and is a 4-year training program, whereas clinical oncology is a little bit longer and is actually under the guidance of the Royal College of Radiologists. There are more exams as a clinical oncologist, and they're done throughout their training. But the key difference is really that clinical oncologists deliver radiotherapy, and they may also deliver systemic treatments as part of their treatment. But the key difference is that they are trained and able to deliver radiotherapy. Whereas medical oncologists, we focus solely on systemic treatment. We probably have a wider range of systemic treatments, which certainly to me is one of the attractions of it. And we are probably more likely to be managing people in non-curative settings, so perhaps a little bit more overlap with other specialties in palliative care, for example. This does vary nationally, so some places they may have different job plans, and in certain tumour sites there may be a bit more overlap, but that's the key differences. And Ali, who's one of our other trainees, will talk a little bit more about the research and clinical trials and how that might differ slightly as well. So Dr. Jagdev already sort of went through some of the attractions of medical oncology, and I think some of the things that I've put here are probably the same. So to me, the first word I came up with is exciting. Things are changing all the time, and it seems like you don't go more than a few weeks without a new treatment being licensed or being approved, and that brings its complexities in terms of job planning and learning about it all, but it's just really exciting. And I've just borrowed this slide from Google. This is just a sort of a timeline. You can see here 2003 to 2011, 1 or 2 new targeted treatments, and then as you get towards the late 2019 2020s, there's just an explosion in the number of new treatments, and predominantly these are being delivered by medical oncologists, and this is likely to expand even more. And there's now going to be cancer vaccines and cellular therapies and all those other exciting advances that we'll be part of delivering. There is lots of scope for research. I've put here, and I think one of our key messages is that you don't necessarily need to have a research background, but as part of your training, you will learn the skills to develop and run clinical trials. We also look after people right from the beginning to the very end of their treatment. So we treat people in the neoadjuvant setting who are very curative. We also look after people who have advanced cancers and towards the end of their life, and I think that range of treatment is really sort of rewarding in its own way, and lots of engagement with other specialties, particularly with some of the toxicities from our treatments. We're now having to learn a lot more about specialties that perhaps previously we didn't have much interaction with. So in terms of the application process, the link here, which you'll be able to get to on the recordings, but it's on the RCP website. Basically, the application form has a self-scoring system based on your portfolio. You then get longlisted to make sure that you're eligible, and then shortlisted based on your scores. And then if you're shortlisted, you'll be invited to interview. And I think it's key to say that the interview is one of the key parts of the recruitment process. So If you feel that your portfolio isn't the strongest, that's not necessarily a huge disadvantage, because a large part of the scoring comes from the interview. So if you're able to prepare yourself well for an interview, that stands you in good stead. This is just indicative of the timeline for this year. So for the round one applications, they open in November. So you've got a couple of months to still sort of tidy up your portfolios and get that prepared if you want to prepare for this year. In previous years, there have been round two applications, but that will all depend on the fill rate from round one, I think. In terms of the application self-scoring, again, all of the details are on the website. I think that it's really key that you don't overscore yourself. That's taken very seriously. And so if there's any sort of doubt, then it's usually better to just underscore, and the panel that's reviewing your evidence may actually feel that you deserve a higher score from that. I think one of the new things over the last couple of years is one of the highest scoring parts on the self-scoring application is about your commitment to specialty. So this is just to flag up that if you're interested, as long as you're making some effort to get involved in some projects or do something to further your oncology experience, that's really important for the assessors for your application. So just demonstrating that you're interested, that you have gone beyond your standard work to do something extra is one of the highest scoring parts. So even if you have a job in oncology, they'd be looking for some extra commitment, some extra work to demonstrate that you want to do this as a specialty. The interview, again, all of this is on the website, but there are 4 stations, and the clinical scenarios are the ones that score highest, along with academic and research. What that is your understanding of research rather than necessarily your background in research. So I think a few people were asking about what tips we'd give for applications. So I think it is useful if you can to get an oncology rotation. And if you do get a rotation as an IMT in oncology, try and make the most of it in terms of projects, teaching, attending extra courses and things. But if you don't have a rotation in oncology, that's not the end of the world. You can still demonstrate your commitment in other ways. So particularly for foundation doctors, you're allowed taster days. So that's one thing you could do to get some experience. And whatever specialty you do during your training, there's always going to be something related to cancer in that specialty. So there's always projects, audits, quips that you can do that demonstrate a commitment, even if you're not doing oncology itself. I've put quip research, going on courses and conferences, doing some teaching. I do have a conflict of interest in that I do run the webinar series, but they are really useful as sort of gaining experience. And if you do attend the webinars, you get a certificate afterwards, which can be used in your portfolio. One of the things I would recommend is that you do try and get your MRCP exams out of the way as soon as you can, because you do need to have that done by the time you start training. You do get extra points at application if you completed it. And also, if you get it done as soon as you can, that leaves a bit more time to then focus on your career development and projects related to oncology and commitment to the specialty. In terms of tips for the interview, if you get there, these are just some links to guidelines that would be really helpful in terms of your clinical stations, understanding some of the guidelines about how we manage acute complications. The NIHR run what's called Good Clinical Practice, which is a training course which gives an outline of how research is conducted in this country, some of the ethics behind it, and some of how it's run. So that'd be really useful to do and complete that. It's free to register. You can just Google Good Clinical Practice and get there. It takes a few hours to do. Make sure that anything you've put in your portfolio you're familiar with, because you can be asked about it. And I think the other thing is see if there's anyone locally that will do practice interviews. So I did some practice interviews before my applications and found them incredibly helpful for preparing for the interview. Just to give you an idea, and I think one of the things we'd like to point out is that people's pathways to training always differs, and there's no correct way to get there. So this is my background. I did my undergraduate degree. I then completed my clinical training. I did do an intercalated PhD, but that is by no means necessary. And I think in hindsight, I may not have done that pathway. But you only do things at the time that you think are right. I then went to Oxford for my foundation training. No academic jobs there. I went to Australia for a year, so going out and doing an FY3 is no barrier to going into training. And I've certainly enjoyed working somewhere else and enjoying a year in Australia. So I would certainly recommend that if people are interested. I then came back to the UK, did my core medical training here in Leeds and completed my exams. I applied for oncology in 2020 and was unsuccessful the first time. So I think sometimes if that happens to you, you feel dreadful for a few days. But actually what it then did was meant that I applied for a fellowship at the Christie in the melanoma team. And I did that for a year, and that made me much more prepared for my interviews and then prepared to become a registrar. So I applied for a second time and then thankfully was successful. And I've now also gone to less than full time over the last few years since having a family. And lots and lots of medical oncologists do less than full time training. So if you are interested in less than full time training, that certainly is not a barrier to doing oncology. I'd say the majority of trainees now are less than full time, and certainly in this region. And then did the exam last year. So I'm now hopefully focusing on the final year and a bit of my training and preparing for a consultant job. So that's just my pathway. If you asked every registrar, their pathway will be completely different. And Ali, who's on after me, will show you his very different route to getting into training. So my sort of take-home message is multiple routes into training. If at first you don't see, just keep going. Eventually, it will help you get more prepared. And I think I was able to start my training in a better place, having done a year fellowship. There's lots of chances to do research, but you absolutely do not have to do that. You do not have to do a PhD to complete your training. But if you do want to, there's plenty of opportunities. And lots of people are going less than full time. So that's everything that I had to say. Here is just some links to some useful websites. And what we can also do is send this out at the end is we have a network of regional representatives across the country. So if you have any questions about a specific region, feel free to ask one of these people here, and that they can give you specific information about the training in certain deaneries, because it does vary a little bit across the country.
Thanks very much, Richard. So I'm Alistair, or Ali. I'm a medical oncology registrar up in Glasgow in the west of Scotland, but I'm also a clinical research fellow. So I'm going to talk to you a little bit about my trainee perspective, but also a little bit about academic careers in medical oncology. I think one of the questions that's come up a lot in sort of the things that people have asked us before this webinar is about a research background. Is it mandatory for applying into medical oncology training? Is it necessary? And medical oncology is strongly linked with careers in research or academia in particular, but a career in academia is not mandatory. It's not even expected to be a consultant in medical oncology, and you don't need a higher degree to get your completion of certificate of training and become a consultant. You don't need a PhD, you don't need an MRes, you don't need a DPhil or an MD or any of those. But in some regions, it does make you more competitive for consultant positions, so it is worth thinking about doing during your training. I think the key thing, though, is that medical oncologists are expected to be able to contribute to cancer research, and they're expected to be able to lead phase 3 trials in the environment that they're working in their cancer center or cancer unit as a principal investigator. But you don't need those skills when you're applying. You'll learn this during training, and it's in fact a key outcome, one of your capabilities in practice that the GMC define on part of the portfolio. So I would say that a career in medical oncology is tied to research, but it's not necessarily tied to academia. You don't need to be a university employee. You don't need to have research time in your job plan to be a very successful consultant medical oncologist. So I'm going to talk to you a little bit about the pathway that I've taken to being a sort of a trainee clinical academic at the moment. Now, the NIHR, the National Institute for Health and Care Research, published this integrated academic training path, where from medical school onwards, you can do your intercalated degrees, you can do an MB PhD, you do your academic foundation year, and then you do your academic fellowships, your clinical lectureships, and then you CCT into a senior lecturer position. That's all well and good, but that's one way of getting there, and there's more than one way to get there. Now, when I was at medical school, I did do an intercalated BSc. I didn't do an MB PhD. I didn't do an academic foundation year. and I didn't do an academic fellowship during the early part of my medical training, my core medical training as it was then. And it's actually only since I started specialist training in medical oncology that I've got my clinical lecturer position, and that I've started doing my PhD, of which I'm just entering my 3rd year now. Who knows what the future holds for me, but this idealized pathway is only one way of getting there. And if you are interested in academia and you haven't got academic foundation year, you haven't got a PhD yet, that's not excluding you from that in any way, shape, or form in the future. Just to talk a little bit about how I did it, I did an intercalated BSc in my first 3 undergraduate years in Cambridge. I then moved to UCL. I did MBBS. I did not do an MB-PhD. I wasn't even sure I wanted to do oncology at this stage. And then I went into foundation years in the northeast of London. I didn't do academic foundation. What I did do at this stage was start thinking about oncology as a career. And Richard talked a little bit about this. I didn't have any jobs in oncology in my foundation years, but what I did was I found projects that would be linked to oncology in the specialty that I was doing. So, for example, I did a quality improvement project when I was working in the emergency department, looking at door to needle times for people with neutropenic sepsis or suspected neutropenic sepsis. Cancer interacts with almost every department in the hospital, and there will be a way of finding a cancer-related project, even if you don't have an oncology job, to prove your commitment to specialty. But to kind of know whether I did want to do oncology or not, I went and did a junior clinical fellowship in oncology at the Royal Free. And again, I think the key thing to say about that is it's all well and good doing these jobs, but to prove your commitment to specialty, it's good to get output from them as well. So when I was there, I did quality improvement projects. I took some posters to, some fairly low-level conferences, but it showed that I had an interest and I was not just turning up to do the 9 to 5. I then moved to Scotland, to the west of Scotland, up to Glasgow for my core medical training years. Again, I didn't have an academic fellowship at that point. And then I moved to the Beatson West of Scotland Cancer Centre full-time. I did a trials fellowship, which was a non-training job, at registrar level, again, to prove my commitment to specialty and to find a little bit more out about working as a registrar in oncology. And I felt that was really useful for my later application. And I was thankfully successful in getting a job. And so I'm training there now. But for the last 2 years and a bit, I've been doing a PhD at the CRUK Scotland Centre as a track clinical research fellow. And again, just to reiterate, a career in clinical academia can take many routes. Now, certainly in England and Wales, NIHR funds these academic clinical fellowships and clinical lectureships. And those are the kind of pathways of integrated academic training. You apply for those through Oriel like you would any other medical job. But outside of that, there's funding available from different bodies for PhDs and for other projects. Like CRUK gives small grants for people that think they might be interested in doing research, for example. But there's CRUK, there's Wellcome. Up in Scotland, we've got the Chief Scientific Officer's Office. There's loads of people that will fund you to do research if you show an interest in it and make a competitive application. And just picking up there, the CRUK Cambridge Centre has their clinical research fellowships. And up in Scotland, we've just opened up our track programme for its 6th cohort. And if you're interested in that, please do email me and I can pass you on to the right people. But it's been a really fantastic programme for me. So that's sort of covering academia and where we are, my experience with that. I then thought I'd talk a little bit about what a job as an oncology registrar involves. You've heard about consultant life from Dr Jagdev, but this is my typical timetable. As you can see, there's time for admin in there. There was time for audit and research in there. And there was also dedicated registrar teaching every week. So it's a really nicely balanced work and life balance. The Wednesday and Thursday all-day clinic, that's a tougher day, but it's balanced out by having the opportunity to do some phase 1 trials, to do some audit research, even some teaching as well. The on-calls, as Richard said, are completely region dependent, and it really depends where you work. In the west of Scotland, we do non-resident night shifts. We do 1 weekend on call roughly every 4 months or so. And we have an on-call week where you and another registrar are taking all the calls And actually for us, that's from throughout the west of Scotland. So all the hospitals and all the GPs, any queries. So that can be busy. But on the whole, I think the work-life balance of what we have is really, really good. Clinical and medical oncology, Richard's spoken about it as well. There is a lot of overlap in the careers, and we work really closely with clinical oncologists. We're both involved in treatments of patients with wide-ranging tumor types and through the full range of treatments from curative through to palliative. We both really depend on MDT working, not just other clinical specialties like the surgeons, but also other medical team roles, including CNSs, the pharmacists, acute nurse practitioners and advanced nurse practitioners. I would say the differences is the focus within medical and clinical oncology. And as we've talked about in medical oncology, and you can see it in the bottom left of the slide here, these are the things that they think are specific to medical oncologists. So more intensive chemotherapy or more intensive systemic anti-cancer therapy, picking up on personalizing cancer treatments for patients. So genome sequencing for patients is becoming a massive thing now, finding out about their cancer's particular genetic vulnerabilities and tailoring treatment to those. And then again, implementing clinical trials at all phases with the skills to lead phase 3 trials as a principal investigator. I'd say that's the main difference between us and clinical oncology, is that focus on the future, the focus on development of new treatments. And that's what particularly attracted me to medical oncology over clinical oncology, because I really enjoy evidence-based medicine and the fast-moving pace of medical oncology. That's not to say that you can't do trials, and there's plenty of clinical oncologists that do trials, but it's perhaps less of a focus. In terms of the educational opportunities, whilst you are a trainee, we have regional and then super-regional teaching, and I know that's replicated sort of throughout the nation. We have local journal clubs, but then we have Pan-Scotland teaching for all trainees in Scotland on a Friday. There's courses that are run by your oncology departments for cell biology, statistics and pharmacology, which have some overlap with the FRCR Part 1s for the clinical oncologists. Various hospitals have specific study days for different tumor sites. You'll find them at the Marsden, the Christie, and you should be able to, get study leave to go to these. ESMO preceptorships are really good. You can travel as well as getting a crash course in different tumors. And then, as Richard said, we have monthly educational webinars, and then we have a trainees weekend every year, which is partially funded through your ACP membership, partially through sponsorship, but we're needing to make a small donation now. But there's also events run by industry, particularly pharmaceutical industry, both national and local, that you can get involved in, and you can get some really interesting learnings from those. And then, you have the opportunity to attend conferences. ESMO's just happened. ASCO happens every year, and there's a lot more as well.
Stephen from the PRSO joined us a little bit after due to some IT things. So I was going to just pause and just check whether, Stephen, you had anything you wanted to add around the application process that we've talked about.
Hi, Simon. I can't turn my video on. Sorry, I don't know why. It says someone's stopping me. So if unstop me, I'll be happy to share. Not so much, not unless there's any specific questions. The guidance for the next year is being updated over the next probably about a month. So most of the guidance for last year is relevant. There's a few changes to self-assessment, which are detailed in the documents area of the website. So some of the domains that Richard mentioned may have changed a bit or not scored anymore. But the interview is exactly the same as it currently is listed on the website. So yeah, most of it's going to be the same as previous years.
Perfect. Thank you. And I think probably before we dive into questions, the other thing I was going to pick up was from Ali and Richard. You both sort of explained about sort of doing fellowships, which, as we said, you can get into the career in a variety of different ways. But I think, again, a flavour of the questions with people asking us how much prior experience, how do you show commitment, just to reassure those of you thinking of applying that we are looking for people around the mid CMT2 level when you apply. So there's not an expectation that you come into this with 5 years of fellowships. As the guy said, it should make you stronger, and it'll make your application easier, but it is by no means a requirement. It goes back to that other question of, do you have to have a PhD or a research degree to get into oncology? And that's sort of a historical throwback to the times when there were less posts I think. So should we dive into questions? Let's take them in no particular order. Satinder, there's a really good one that was pre-supplied, or anyone can chip in, but will medical oncology slowly be faded away as there seems to be an increase in clinical oncology trainees? I think we might have a different view of that as a panel.
Yes, absolutely. And I think I alluded to that in my section. So there has been an expansion in clinical oncology posts, but there's also been an expansion in medical oncology posts, appreciating that we are going to need specialists in the future that are trained in the delivery of systemic anti-cancer therapies and complex treatments. And so in terms of, we've talked about some of the commonalities in the training, and certainly the OCS year covers that. But actually after that, the training branches off, and it's very clear that to train as a clinical oncologist, you need to be able to devote the time, yes, to the SACT training, but actually to the radiotherapy training. And again, from ST4 to 6. There really has to be that focus on developing the expertise that you need as a consultant managing those complex patients with complex treatments, looking at different settings. And the demand is just increasing, really, in terms of the aging population and increasing rates of cancer, but also in terms of the development of our services and really making sure that patients have access to treatments, whether they're close to their locality or somewhere in their locality. And certainly, there are disparities sort of regionally and nationally in terms of how services are configured. So, and again, acute oncology figures into it as well. So yes, that is shared between medical and clinical oncology, but oftentimes it's the medical oncologists who will have acute oncology in their job plan. So I don't think we're going anywhere very soon. I think there'll be more of us.
Thank you. And then the other pre-supplied question, I might give this to Richard and Ali, if you don't mind, was around the sort of research. Obviously, you guys have talked about the clinical trials research, but I guess there's a theme here of, I've put several questions into one, if you don't mind. Is there an ideal time to do your higher degree if you wanted to do one? And are there any thoughts on where you do that? Does it have to be clinical? Could it be basic science? I don't know if you wanted to give anyone your thoughts on those, if you wouldn't mind.
Yeah, happy to. So my PhD is very much a wet lab PhD, but that was very much a deliberate choice by myself. I have colleagues that are doing PhDs in big data, and will never set foot in a laboratory in their life. They'll do lots of computer work. I have colleagues who did a PhD looking at the impact of cancer clinical trials and what that actually meant for patients, and they've been very successful doing that. And there's colleagues who have a sort of a wholly clinical trials based research as well. So I think it's really very much a personal thing and what you would want to get out of that research period, and what you'd want to get out of program opportunity. Someone had asked, I think in the thread about, is it possible to get involved in sort of translational or basic laboratory research in medical oncology? Absolutely it is. And there are people who have careers as consultants who still have a laboratory footprint. That's usually done through the academic route. That's usually done as a university employee. But it certainly is there's plenty of that involved in medical oncology. Yeah, so I think it's really it's a personal preference as to what research interests you and invigorates you, and that's what you should focus on.
Thanks, Ali. Richard, did you want to add anything to that at all, or pretty
No,
confident?
no, I don't think there's anything. I think that was really well put by Ali. Yeah, I think it's what you're interested in. Some people do very clinical trial based research. Yeah, so I think whatever it is. And I guess in terms of the timing, again, that's partly going to be based on your personal circumstances. I think there are certainly benefits to doing it if you're already in a training program and taking some out of program time. I did the MB PhD program, so I did that during medical school, and the concern with that is the further away from your, if you want to be involved in research, the longer you leave it between your PhD and doing further research, the harder it is to get back into it. So I think most people would do it once they've got a training post, but that's again certainly not how you have to do it.
Yeah, brilliant. Thank you. I guess we don't want to spend too long on high degrees and the research bit, but it comes back to worth getting in touch with someone to mentor you in the region you're looking at. I think the contact list you put up, or talking to your TPD or the academic leads, because each centres will have different opportunities and different projects and trainees with different experiences. So worth finding out what people have done before as well, I think. There was a question we had around palliative care, formal palliative care within our curriculum. So again, I guess Richard or Ali, did you want to comment on sort of training within palliative care and symptom management as how that feels as a registrar?
Yeah, so I think that's from Ishika, who also asked about tier 2 and tier 1. I don't know if that's something you wanted to
Yes, thank you.
to
Good
cover as well. So I can certainly mention about the palliative care. So there is no, as part of the curriculum, one of the CIPs is managing patients at various stages of their cancer, including palliative care, including at the end of their life. So particularly on the wards, managing patients at the end of their life and palliative care is an integral part of medical oncology. So we don't necessarily have formal training in it, but it's a key part of your sort of training as managing these patients. And we have lots of overlap with palliative care. I'm sure if it's something that for some people that they're really interested in that aspect, I'm sure there's out of program things you could consider to try and get more experience. But it's not necessarily you don't go to a hospice, you don't necessarily get exposure to palliative care teams in the community, but it's a really important part of our training. And so I certainly feel that we get a lot of experience and are good at managing the basics of palliative care.
I mean, a lot of what we're confronted with on the ward is often patients who have palliative care needs, and we work very closely in Glasgow with our hospital-based palliative care team and have very good relationships with them, and they're always very happy to teach us as well. But actually, our TPD for our region has we have a block where we do actually join the palliative care team and go into hospices and things like that. So it's a bit more formalized. So again, it will be region dependent into what kind of integration you get with the palliative care teaching, but it's certainly a really important part of what we do. So whilst there's not necessarily formal structure, you'd probably be expected to do some workplace-based assessments in more palliative things, and certainly learning from the palliative care team, I think. And as I said, in Glasgow, we do get it slightly integrated into our training as well. So
we have lots of teaching on palliative care, and your ward-based ACATs and things will include your management of palliative patients.
And then there was a question about sort of the acute oncology as well. Simon, I don't know if it's worth addressing that as well.
Yeah, I think what I'll do, should I quickly answer the tier, the group 2, group 1,
Yes.
group 2. There's no immediate change planned. These things are always reviewable, and Satinder can correct me, but we're not changing anytime soon that we're aware of. I don't think any of us would want to, but I guess thinking about those future careers that we looked at, and depending on what sort of career as an oncologist you want to develop, Satinder was saying, you might want more general medicine if you were going to go down an acute oncology line, or depend if you're working in a region where you have more interactions with the medical teams, you might find that more medical experience was more useful to you. And I've certainly had trainees talking to me about wanting to do more, or feeling that palliative care doing general medicine meant we were missing out. So again, comes back to what Ali and Richard were saying. I think there is no one linear career path. You know, you don't have to just get on the treadmill. You can have a think about your future consultant post and what that looks like. Ali, sorry, did you want to go, and you picked up another question there?
Yeah, people talking about acute oncology and gaining experience in that. Again, particularly with the new acute oncology common STEM year, between clinical oncology and medical oncology or ST3, there's actually now quite a big focus on acute oncology, and kind of the discussions that we've been having with the RCP about what medical oncology should look like. There's more of a focus on acute oncology now, so that there'll be plenty of training in acute oncology throughout your registrar years. And certainly, as Satinder said, there's many job plans now which for medical oncologists which will have acute oncology as a big part of it. And there's an acute oncology society as well that, if you're really interested, I think it was sorry, I haven't got your full name, Malika Haider. If you're interested in acute oncology, you could even look into joining that society. They have meetings, and in terms of gaining experience in it, most hospitals will hopefully have an acute oncology service. So if you introduce yourselves to them, they'll hopefully be able to give you some tips and some experience as well.
Brilliant. I'm conscious of the time, but what I was going to suggest is I think we're all happy to keep answering questions, and would plan to press on if people are happy to listen. So we don't want to miss out on these. I can pick up, and I saw a couple of hands go up, but we can't really do hands and open the mic. So if you have got burning questions, please do put them in the chat. But Sherry, you asked us, is there only one intake because of your less than full time? It has varied year on year, depending on numbers of posts. Traditionally, we've run one round going back a few years because we had fewer posts to recruit to, but we do sometimes do other rounds. Stephen would correct me, there are many options for rounds throughout the year. And I think has also just let me know that this is something which is also under discussion at the PRSO. So for the moment, possibly one round, but do keep an eye on the websites, because there may be others. And again, I can't emphasize enough, you may not realize this when you're a foundation or core medical, but as a training program director, I love it when people get in touch with me and ask about how they get into the specialty or how to do it. And I think we'd all feel the same way. We'd much rather someone made contact. So don't feel shy about using those emails that Richard and Ali put up. Try and make contact with someone and try and get some advice about what the options are. And I think that probably hopefully deals with Jessica's question as well about trying to get contacts. Email one of us on that list, and we'll try and get you in touch with someone.
Simon, sorry, I'll just come in quickly.
Stephen, yeah, please.
Question. So there are only 2 rounds in a year, certainly as things stand, and you either have to be completing IMT by the start of August for the first round, or currently it says the start of January, but we're going to move it out to start of February for future years. So basically, depending on when you finish IMT, depends on which round you could first be considered. Every specialty is given the opportunity to enter the second round, and then it's a specialty decision based on various factors, most of which is post availability. So it's not ruled out, but a decision wouldn't really be made until after, I guess, Simon, unlikely to be made until probably May or so time, when we know the wrap up of this year's recruitment.
Yeah, spot on. It's around that time. Yeah, so thank you, Stephen. That's really helpful. So question to the panel, any organizations we would recommend you join as a trainee to, I think we've highlighted a few, but let's be Ali and Richard, who would you recommend joining?
to tie in with the other question about the ACP, unfortunately, at the moment, the ACP is to do with the ACP constitution. You have to be a specialty trainee. There have been discussions about whether that changes, but unfortunately, for the time being, that is the case. Ali's already put about the UK Oncology Society. I think ESMO, the European Society of Medical Oncology, you can join, and that's, I think, £50 a year, so it's not too steep. And they do some webinars and sort of education activities as well. So that's potentially, but yeah, unfortunately, the ACP that's not the case at the moment.
Yeah, I'd reiterate what Richard said. ESMO have a young members fee that's not too much money. It obviously shows commitment to specialty because you're joining a society, but it's also got really fantastic educational resources available as well. So I think joining ESMO is well worth it. That would be if I had to join one society, I think it would be ESMO.
And sorry, just for the people that aren't aware of that, ESMO is the European Society for Medical Oncology.
Yeah, I'll post a link in the chat. If I could pick one, if it was an option, ACP would be. For those of you that are medical students on here, there is bonus, which is the undergraduate society. I'll find a link for that as well, and they're actually linked in with the ACP as well. So that's worth it for medical students if you're an undergraduate.
Brilliant. Thank you. I think the other one is the American Society of Clinical Oncology, but I'm pretty sure you have to be on a training program to get their discounted rate, but that's also quite cheap. But the ESMO online and learning resources are really quite strong, aren't they? Satinder, there's a question from Alex about on-call responsibilities, both in training and post-CCT. How would they differ between Med-Onc and Clin-Onc? For example, if given we can't deliver radiotherapy, how would you manage cord compression? Or are two colleagues on at the same time? How do you fancy that one?
Yeah, no, absolutely. So in terms of the trainees, there are many places now where actually there is a joint on-call rota that's run. And overnight you may have, so for example, here at the Leeds Cancer Centre, there's a joint rota for out of hours from 5 p.m, but you will have a medical and a clinical oncology trainee on up to around kind of 10 o'clock, and then there'll be just one registrar on either medical oncology or clinical oncology. So certainly there are, from a trainee perspective, there are joint rotas that go on in terms of after training. So often there will be a medical oncologist and a clinical oncologist on call, non-resident, but often kind of around in the evenings doing ward rounds, etc. And so to answer the question about the spinal cord compression, certainly there would be access to clinical oncology out of hours. Does that answer the question?
Yeah, thank you. I think so. So just working down them, Pratyush, you asked us, is there any way of getting in without completing IMT straight from FY2? I think the short answer is no, but the guys have sort of outlined. The only other thing I'm thinking about there is there are some ACF posts at IMT in certain regions, so you wouldn't be avoiding IMT because you have to get your membership, but you could be doing something that's oncology specific, but there's not many of those around the regions.
Just to pick up,
go Ali, yeah, please.
In terms of alternative routes, you can do ACCS acute medicine as well.
Thank you. Yep, good point. And I guess equivalence as well, but that's a different thing for if you've trained overseas. And so here's an interesting one from Ashish. Is there overlap between hematology and medical oncology? Differences between the two career options other than the types of cancers? So Tinder, shall we have a go at that one?
Yeah. So in terms of the training there and the multiple disciplinary teams, there is and medical oncology, there's not so much overlap. From the clinical oncology point of view, you know, there are some radiotherapy pathways in the treatment of, for example, lymphomas. So there will be some joint MDTs, etc. But if we're thinking about the you know, if you're thinking about the posts in IMT prior to applying, certainly, you know, the types of skills that you're gaining in terms of managing the acute complications of oncological treatments and managing sick patients and thinking in an oncological way, you know, you can get those through a hematology post as well as an oncology post. But really, you'd have to look closely at the hematology specialist training pathway. They have different exams. They have a different structure to decide whether, you know, which pathway you'd want to go down, and the jobs look very different as consultants as well.
Thanks, Satinder. I guess it's a little bit like a question we had before about experiences with pediatric oncology, where they're different specialities with different entry points. So that would be, you enter that as a pediatrician, and then you have another round of applications, don't you? And then within hematology, of course, your training is in general hematology and the different aspects, and then you specialize in the malignant part as a consultant. So depending on your region, you may have more or less overlap with some of the heme teams, but again, you'll see different things in different regions. So talk to your colleagues, I guess.
Do you mind if I
please? Yeah, go.
Just because my wife is a hematology trainee, so I've got a perspective of what she does. So there are a lot of similarities that Satinder picked up on, particularly the communication skills side of things, complex communication, you know, dealing with patients who are unwell from their cancers and also unwell because of the consequences of their treatment. I'd say that hematology, as Simon picked up on, the general hematology is a big part of it as well. So you're not just dealing with hematological neoplasms, you're dealing with sickle cell, you're dealing with platelet disorders, you're dealing with all the general queries that a hospital will have in hematology. So I'd say their on-calls are busier than ours are, and the requirements are a little different. They're also a little bit more involved in the diagnostics than we are. Quite often when we'll see a patient for the first time, they'll have been worked up by another specialty. They'll have had their CT, they'll have come to MDT, but quite often someone in hematology will present with lumps in their neck to the hematology clinic, and then the hematologist is involved in taking them throughout the diagnostic and then treatment pathway. So there are some kind of subtle differences, and also particularly in transplant, the patients are a lot sicker than we get. These are patients that are really taken to the edge of what they can tolerate. So the acuity is a bit different as well. Thanks.
No, Ali, that's really helpful. Thank you. And then we have a follow-on from Alex, which is probably the million-dollar question here. How do we feel the job prospects differ between a med-onc and a clin-onc post CCT? And Alex, you've commented about med-onc consultants being found more often in specialist centres, tertiary hospitals, and less so in smaller DGHs. So as you said, from a service provision, if you're a trust, you can see why someone who can do multiple things might be more employable. But how do we feel about those posts? So again, Satinder, did you want to sort of comment about what we think is going to be the sort of expansion and continuation of what we're seeing now in terms of the increased in numbers of NTM posts and where this leads us?
Yeah, no, absolutely. I think I think you know, we've acknowledged that actually, you know, cancer care in general, there is a need for physicians that are trained in cancer care, and that's true for the systemic anti-cancer therapies, and that's for other modalities as well, and certainly true for radiotherapy as well in terms of the demand. And in terms of specialist cancer centres versus tertiary hospitals, so there is some regional variation, but certainly the radiotherapy machines, the LINACs, and the facilities tend to be in the specialist cancer centres. So most often you will find that clinical consultants are based at the specialist centre, but then will do have a visiting service to the district general hospitals in the region. So they will have a visiting model. In terms of medical oncology consultants, again, that varies really across the UK. There are some areas where, again, the med-onc consultants are based in the centre, but will visit the cancer units. In our region here in Yorkshire, we have resident medical oncology in some of the district general hospitals around West Yorkshire. So there are different models depending on where you are. Certainly the demand is increasing, and what we're finding currently is that a lot of places will have vacant posts, and there is not the competition that there used to be for applying for consultant posts, and certainly geographically, trainees are quite often wanting to stay in a geographical region, as opposed to thinking about the type of tumour sites that they're applying for. So there's a lot of it's really very multifactorial. I think it really depends on the region. It depends what the needs are in the region. It depends on the setup of services, and yes, I mean, I think if you're thinking about difficult to find a job as a medical oncologist in a smaller DGH, I would say it was probably the other way round at the moment. In terms of service provision, yeah, certainly. I mean, clinical consultants have, they have their training in radiotherapy, but do have training in delivery of SACT. But there are certain tumour sites and certain treatments that are really only provided by medical oncologists because of the need for delivery of more complex patients, more complex treatments to patients who may become more unwell. And again, we've talked about acute oncology services as well. So yeah.
Yeah,
again,
thank you.
I think it's multifactorial.
Absolutely, and as you say, we're just, yeah, everything's moving, isn't it? We've come from a time where I think was it 90% or 95% of our posts were in London, certainly over the time I started, and everything's being redistributed as we realise that we need to get to where the patients are. So I don't think there'll be a shortage of jobs. There's a quick one from Ang asking, could you get involved in academic research as an international medical graduate without a UK undergraduate degree? No problem. You just have to apply and find funding and opportunities which you'll be able to apply for. So we're keen that people who want to do further research do that in the training program, and your TPDs and academic leads would support that. Equally, I think, Satinder, you said you might choose to develop skills in another area such as leadership, management, education. These are all things that we will need colleagues to take on in the departments, so they'll all make you marketable as a consultant.
Yeah, sorry, just as
please,
I think
yeah, go Rich.
We have had some clinical oncology, but I think also some medical oncology registrars who have been involved with the chief registrar program,
yeah,
which is sort of run by the RCP and is, if you're interested in leadership and management.
Brilliant, thank you. I might take a stab at this one first if people don't mind. But so, Adriella, you asked about interaction between medical oncology, ITU, ICU, around stem cell transplant patients who might benefit from ITU. Again, it's going to be different in each region, and we talked there about the interactions between hematology and patients who are on the sort of on the lymphoma side. You've got patients who may be having high dose chemotherapy for germ cell. And then we looked at the future, looking into the future and thinking about sort of cellular therapies. And certainly we're having conversations about how any of us are trained to be able to manage patients who are going to be acutely unwell. So certainly in our region, we have a fantastic interaction with colleagues on the high dependency ITU for those who need that extra support. So I think, again, if you're more acutely minded, there's definitely opportunities for you to be involved in looking after those acutely unwell patients. And it will depend a little bit on each hospital setup as to where those patients are looked after some hospitals in London have high dependency units on their oncology wards. Others, certainly in Cambridge, we move patients to an HDU, and I'm sure others do it differently. I know people are heading off. Richard, Ali, there's a question around, will there be a feedback form? Because obviously we'd love to grab feedback on what's useful and what wouldn't be useful, but I'm guessing we will email people afterwards and ask for feedback. Is that right?
Yeah, so yeah, we'll send a form around in the next 24, 48 hours asking for
Amazing.
feedback. Yeah.
So I'm conscious it's getting into the evening and I'm sure people have got things to do, but I think we've cleared the questions. If we haven't and we find one and we think we should have answered it for you, we'll drop you an email. But I think just closing comments. Hopefully you can see that slide there that says there's a date for your diaries. We're going to do something again, but we're going to do it jointly. So considering medical oncology, clinical oncology, and we're going to do that as a joint webinar with the ACP, Association of Cancer Physicians, and the Royal College of Radiologists. So the two specialities on the 21st of October. So if you go away and think of other questions before those first rounds applications go in, you have another chance to come back and listen to us and hear us all in one place explaining the breadth of specialities that look after patients with cancer.
I assume that's in 2024, not 2025.
Apologies. Yes,
yeah.
It is 2024. Yes. Never type the slides while other people are talking. Thank you. I should change that. Thank you. And I guess I'll hand over to Satinder for sort of comments. But I guess my final comment will be we're really approachable. So do make use of those contact details if you've got questions. If you want to know what the career is like, if you've got questions about the region or how the rotations work, get in touch with your trainee rep, TPD, and we will, I'm sure, be really happy to try and answer questions. Much prefer that to people going through the application and sending you a panicked email when they may or may not have got a job 250 miles away from where they live and they're really not sure what to do with it. So get in touch. But Satinder, did you have any final thoughts?
No, just to say, I think just to reiterate that, if you have any questions, please ask. I mean, there are plenty of people to reach out to, as we've said today, and you also have the contacts for Richard and Alistair, myself and Simon. So I think, any questions, just get in touch and do seek out your local trainees and local consultants, because we love to hear from you, and we're very enthusiastic about our specialty, as you might have gathered, and very keen to encourage anyone who wants to apply. So and just to say good luck really with the process.
Brilliant. So
I've shared the region ACP regional reps. This is trainee reps. So this isn't for the oh sorry, Ali, I've got your email address wrong. This isn't for the training directors. That would be happy separate, but a lot of this information on the ACP website. And the other thing is we don't have representatives for every region in the country, but I'm happy for you to email me if you're in a different region. I'm sure we'd be able to find somebody in that region that we can put you in touch with.
Brilliant. So thank you. Thanks. We'll leave that up there at the end, and just thank you all for making time to join the panel. Stephen, thank you for joining us and giving us your expert input as well. And thanks to everyone for joining us. Hopefully that was useful. And as Satinder said, good luck with your choices and applications. Good night.